3 on the West Coast, and you are in the most important place of the entire week. I am so glad to have you here. We've got a couple of different feeds going on. We've got Facebook and LinkedIn and YouTube over here. We've got a couple of different Instagram feeds. We've got New Life Fertility here. We've got Randy Fink, MD, right here. And what a pleasure it is to see everybody. And I hope that your Thanksgiving was as wonderful as mine. What'd you do? Did you eat a lot of turkey? I sure did. Got to spend some wonderful time here with family on the Gulf Coast, and Thanksgiving to me has always been a very important time. But I do know it's a stressful time for a lot of folks, and especially when we are dealing with issues like fertility, it can create an awful lot of angst in our world when people are asking, when are you having a baby? And, when are you having the next one? And what are you guys doing? And, or even if not that, why are you still single? And, and all that business that seems to crop up at the holiday times that just can make things that much worse for us all. But, we've got each other here, and this is the place that it's my favorite place to be all week. And that's where we can talk about all those things that are important here. So let's say hello to all the folks who are joining us here. We've got Kowser. Hello, good evening. Hi, Jessica Vaughn, Mrs. V. Nice to see you as always. Hello to CNY Fertility. GPTV, hello. My dear friend Brandis is here this evening, or at least was a few minutes ago. Brandis is the wonderful nurse practitioner I used to work at. We used to work with at CNY Fertility. Hello to Stephanie there on Facebook. Thank you for being here. Blackskin Beauty, nice to see you. If we can't get to your questions here on the program tonight, then by all means, please email them to me, and that's askfertilitywithfink at firstfertility.com. Again, askfertilitywithfink at firstfertility.com. So let's see, what do we have to talk about here tonight? Well, lots of stuff going on. Thanksgiving, as we talked about, it's kind of a big time for everybody. We've got a lot of other stuff coming up here in this next month. It's the 1st of December. Boy, time has really flown by this year, but we've got the Christmas holidays, we've got New Year's, Hanukkah, all that stuff coming up. And again, these can be very stressful times for folks. And so I'm curious to know from all of you, what do you do to deal with that stress at the holiday time, especially when it has to do with things like having a baby, things like being pregnant, things like adding to your family. Sometimes family really means well, but they can put a lot of undue pressure on us when it comes to things like making a family. And so how do you handle that? I'm really curious to know. Please chime in here and let us know kind of what you think. Full of pineapple. I like that. Victoria Lynn, hey there. Hi, honey girl. Marlena, Amber, nice to see you this evening. Hi, Rosa and Lexi. And what do you do? Amber says she works out and cleans. Work out and clean. All right. Well, I guess that's one way to do it. I have to say, I wish I could work out more. It's just never been something that I have really loved to do. And so, there's so many people out there who love to work out and find that it is such a, it's a place that you can go to quiet your mind. For me, it just doesn't, it's not something that I enjoy. And so inherently I am there and I'm feeling like I'm torturing myself every minute there. So it doesn't necessarily clear my head, but I appreciate it, Amber, that it does for you, and it shows. And so that's a really good thing, because that's the other thing for me. I can work out, and it never seems to make a difference in the way I look, or the way I feel. So then it's kind of like, all right. There we go. Hi, Angela Sack. Good to see you here as well. Blaxican Beauty says, I keep getting asked, when am I going to make my daughter a big sister? And if they only knew how hard it was. And yeah, and I think that's the thing that people don't. So, one suggestion that I think I got last week was where the answer was, I'm working on it. Thank you for asking. And that's enough to shut them up. I'm working on it. Thank you for asking. That kind of tells them, okay, don't need your help here. Appreciate your thought. Appreciate you asking, but we're not going to talk about it because you don't know what I'm going through and how you're not walking in my shoes. So appreciate you asking. I'm working on it. Rosa asks, is a day 7 high-level mosaic embryo worth transferring? Well, you got a couple of things going on there with that high-level mosaic. First of all, it is said that, so what is a mosaic embryo? A mosaic is an embryo that, so we have 2 sets of 23 chromosomes or 46 chromosomes. So in a mosaic embryo, one of those embryos or one of those sets of chromosomes is normal, and there is an abnormality in the other set. Now, our body may have the ability to correct some of that damaged DNA. And so in general, it is said that a mosaic embryo is not a throwaway embryo. A high-level mosaic means that, a significant portion of the embryo is shown to have some abnormal chromosomes. And when you combine that with a day 7 embryo, day 7 embryos do not perform as well as a day 5 or day 6. So what I would say is, if that's the embryo that you have left, then yes, it's worth transferring because it may just get you a baby. There are a lot of facilities that will not, a lot of programs that will not transfer day 7 embryos because they perform less well than the other embryos. But if that's what you got, I have met plenty of baby who came from a day 7 embryo. So, and I've met plenty of normal baby that came from a high-level mosaic. So I would say, in general there, sorry, I feel like I've got some piece of my hair or something in my mouth there. If that's the embryo you have, Rosa, then that's the embryo you transfer. Now, would that be the first embryo I would choose to transfer? No, I would rather have a different embryo, one that who has numbers that look a little bit better. So, but if that's the one you have, then yes, that's the one you transfer. It is not a throwaway embryo, but it certainly doesn't have the same chances of giving you a live birth as does a different type of embryo. Let's see here. Love to the Bama gal. So I have a very special message to send out tonight. So tonight is December the 2nd. Are you aware of what happened on December the 4th, many, many, many years ago? That was my mother's birthday. So happy birthday, Mom. Are you turning 25 this year? I think it's 25, but I will get the honor of being able to go and be with my folks in Mobile, Alabama for my mom's birthday on Thursday. So I hope the whole world can wish you a happy birthday as well. I am so lucky to have you. Hey to Pretty Girl. And Honey Girl says, I downregulated with Depolupron for 2 months and it got me pregnant. Sadly, the baby didn't stay and it's been over a year. Should I do it again before the next transfer? And the answer to that is yes. If it's been a year since you suppressed with Lupron, presumably due to endometriosis or due to the BCL6 marker, then I would say yes, I would recommend that you do suppress again before doing another transfer. So it is said that the suppression probably lasts 3 to 6 months in most people. I'm very sorry to hear, Honey Girl, that pregnancy did not continue. That is in all probability as a result of the embryo itself. So that suppression part using the Lupron is designed to be able to get you to be able to really to implant the embryo. So it's for implantation. You were able to get that, but there was an embryo problem that kept it from growing. So yes, I would recommend that you suppress again. Pretty girl Key, I believe that says, what should I do right after a day 3 FET? Bed rest or walk or move around? Definitely not bed rest. We do not recommend bed rest after an embryo transfer. In fact, the data shows us that the outcomes are worse in patients who try to do bed rest. So I recommend you just kind of live your life. I say, you want to take it easy for a couple of days, maybe for the first 2 days after your embryo transfer. And that means don't do anything that's overly strenuous. So what I would always say is no alligator wrestling, no bungee jumping, no extreme snowboarding, no helicopter skiing, those kinds of things. But walking up steps, going to work, kind of doing your job, living a normal life, I do think that is okay. Bed rest, I specifically don't recommend for 2 reasons. One is because the outcomes are just not as good in folks who have done bed rest. We want you moving around. It probably improves blood flow to the uterus, would be my guess, is the reason why there. And secondly, because when you are stagnant in bed, you are more likely to get things like blood clots, especially when you've been on all that hormone business and hopefully you're in the business of getting pregnant right then. Those things can increase your risk for blood clots. And so being the stasis of blood or being static, not moving around, can really increase your risk. So yeah, that's why we recommend do walk and move around. Would an HCG wash and lipid infusion help with a day 3 embryo? And I think the answer there is it certainly won't hurt. So, both of those things, the intralipid and the HCG wash are immune add-ons, if you will, things that we can do to try to address certain types of immune problems. We don't always have the ability to test for all these immune problems. And so what some practices do is that they offer this to the general public. They offer this to the general population of folks thinking that, well, we're treating everybody, so we know that we are helping some people. The question is who exactly are the people who benefit? And that is a harder question. What you're asking is, will it help? It may help, but it certainly doesn't hurt. So if you have the opportunity to do it and it's not too much trouble and it's not overly expensive and it's available to you, I do think that it's something that you can do. Hi, Indepino Journey. Nice to see you here as well. Mrs. Villarreal says, happy birthday, Mama Fink. Look at there. Pretty girl says, happy birthday, Mommy Fink. You like that? I hope my mom is watching this. I hope she gets to see this. The whole world wishing her a happy birthday. Let's see. Can scar tissue in the uterus, Angela asks, be mistaken for adenomyosis? I had an MRI, but the report didn't show any scar tissue, but I clearly have a lot of scar tissue seen in a hysteroscopy. No, I think those are really kind of looking at 2 different things. So scar tissue is something that happens really inside the cavity of the uterus. And so scar tissue is when you've got some what we call synechia or bands of adhesion or scar tissue that may be connecting the top to the bottom or maybe the side to the side. Think of it as kind of getting sticky so that the cavity becomes less of a cavity and more of something that is kind of squished together and there's less space on the inside. I would not necessarily expect an MRI to be able to show synechia inside the cavity or scar tissue in the cavity. Adenomyosis is the process where the glandular tissue that lines the cavity, instead of just staying in the cavity, takes a drop into the muscle of the uterus, into the uterine muscle or the myometrium. And an MRI is excellent for being able to demonstrate that process of adenomyosis. So I think they're very different things. If there is some kind of contrast material that was placed inside the uterus when you did the MRI, and they don't typically do that, but if there's a little fluid in there or something, that may be able to show some scar tissue. But really the MRI is designed to be able to look kind of through solid objects, but not to be able to see things that are sort of filling up a potential space. And that's what we call the uterine cavity. It's a potential space that in nature, that cavity is collapsed. And as a result of it being collapsed, you can't really see what's going on inside of it. So therefore, it's a potential space. It has the potential to create a space. And really, that's kind of what that means. So a hysteroscopy is really the best way, or even a saline sonogram, to be able to see what happens there inside the uterine cavity. Angela asks, how many days of stims is considered too many days, which can result in poor egg quality? So there's no absolute on that, but the ideal number of days for stimulation for IVF is between 9 and 12. So that we know here that if the stimulation was less than 9 days, there may be an effect on egg quality. And if that stimulation is greater than 12 days, there may be an effect on egg quality. Now, that said, again, I have seen plenty of people who have made embryos and gotten babies as a result of 6 days of stim, or even 14 or even 15 days of stim. By the time we're getting to something like 14 or 15 days of stim, we're talking about a pretty long time. You've spent a lot of money on medication, and we are already going to be expecting to kind of be behind the 8 ball there. You're not performing as well as we would have anticipated. And so I think if it's going that long, it means let's take a serious look at what's going on there and see if we can have some realistic expectations of what we can recover. But the ideal stim time is between 9 and 12 days. Pretty Girl asks, should I do boosters, HCG boosters, after a day 3 embryo transfer? So it doesn't so much matter what type of embryo you transferred to know whether boosters are the important feature. HCG boosters is where you take the pregnancy hormone, you take a little bit of it, usually like 250 units, and you inject it subcutaneously, so kind of right, in the skin of your tummy here. And it's metabolized in the body ultimately as progesterone. It will increase your progesterone. Now, if you've done a medicated cycle, or what we call a programmed cycle, where we're giving you the estrogen and usually progesterone in oil, using an HCG booster is probably really not that useful, because we're already giving you a ton of progesterone. You're getting a ton of progesterone from the progesterone in oil. Now, if you have done a natural or a modified natural cycle, where you have made your own egg, you've ovulated, that means you made your own estrogen, you're making your own progesterone, then yes, 100%. I would love you to be doing an HCG booster, because it does increase your progesterone level. And in that natural scenario, increasing the progesterone level may be beneficial. So whether it's a day 3 or a blast transfer, I think, Pretty Girl, it depends on the type of cycle you're doing, whether it's medicated cycle or whether it's a natural cycle. Let's see what else we got going on here. Hello, Pleasant Hill supporter, admiring wife. Let's see. Indipino Journey says, why do some doctors say that DHEA is not helpful for women over 40? So, DHEA is one of the evidence-based supplements that is said to be helpful for those with diminished ovarian reserve and particularly those who are over, depends on the age you think, but certainly over 40. DHEA, when taken as a capsule, and it's recommended to be 25 milligrams 3 times a day for diminished ovarian reserve or for women who are over 40. For some women over 40, I should say. That's the recommended dosage. But so the issue is there's some folks who, for instance, it may not be helpful in. If you have polycystic ovarian syndrome, for instance, and your androgen levels are high, things like testosterone, that's what I mean by androgen, then using DHEA actually may be harmful because you're increasing the testosterone even more, and that testosterone can prove it can prove to be bad for you. DHEA is a precursor to testosterone, but it's also a precursor to estrogen. So that's probably why it's beneficial. 25 milligrams 3 times a day. Some folks will say, nah, I don't recommend that. And it may be, they have their own reasons, but the evidence, the data, the studies on it are really quite clear that if you don't have PCOS and you are of diminished ovarian reserve or over 40, 25 milligrams 3 times a day of DHEA is beneficial. Oh, you hear this, Mom? I hope you're listening. Rosa says you raised a great son. That's right. Make sure you tell that to my brother, Rosa. He needs to hear it. He raised a great son. And that son is me. Sibling rivalry begins at the embryo stage, and it continues on throughout the life. Amber says, what is your stance on delayed umbilical cord clamping? Wait until no color or, all right. So we're talking about what happens at the time of delivery. And the thing about delayed cord clamping is that, all right, so here's what happens. You have a baby. The baby comes out, and the umbilical cord is still attached to the placenta. And blood is still flowing through the placenta, through the umbilical cord, and to the baby. This thing about delayed cord clamping is where rather than, so it used to be as soon as the baby out, you put 2 clamps on the cord and you cut between and you hand the baby up to the mom. That, baby is now breathing air on the outside. There's no reason to have to get blood from the oxygenated blood from the placenta anymore because the baby is breathing air. Inside of you, the baby doesn't breathe. Well, there were some studies that looked at, delayed cord clamping was, kind of a fringy sort of thing. And then it became really pretty mainstream. And the studies show APGAR scores tend to be better. Risks of anemia to the baby tend to be lessened as a result of delayed cord clamping, and some other kind of good stuff. And so when I was delivering babies, that was my practice. And people would say, they would come in and they would, put their foot down and they would, point at me with their finger and say, I demand that you do delayed cord clamping. And I would say, well, that's what I do anyway. So I think it's a good thing. But do you wait until there's no color? Well, you may be waiting a while for that. And there's also some theoretical risk of getting some backflow of blood coming out of the baby going in the other direction. So, I kind of would leave the cord until it appeared to stop pumping. It would start to get a little paler until I felt like it was the right time. And then we would cut the cord. Now, in my practice, I would always ask dad or whoever the support person is that's there with mom who's delivering to cut the cord because, they deserve to be a part of the of the process too. And so it's a really nice thing, and you can't hurt anything and you can't do it wrong. And so it's just kind of a special thing. And a lot of people would say, I don't want to. And I'd say, no, 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 no. Here, take the scissors, put them in your hand, just cut right there, because at the end of the day, you'll be glad that you did that. So, but I do think delayed clamping is really probably for the most part standard of care now in most circumstances. Blaxican Beauty says, I'm 37 with diminished ovarian reserve. I have a low AMH and only one tube, my left tube. So my hubby and I decided to try on her own before we consider IUI due to our funds. What kind of protocol would you recommend us for timed intercourse? So I would still recommend for timed intercourse that you do ovulation induction. All right. So under normal circumstances, your ovary releases an egg, right? And that egg hangs out and waits for a sperm to come along and fertilize it. And if it does, woohoo, you're pregnant. Body says, let's do all the things that we do when we get pregnant. And if it's not, the brain says, okay, fine. Shut off the hormones, clean everything out, and we're going to start again fresh next month. That is to say, we're going to have a nice period, clean everything out, and then we can try again. Well, releasing one egg is what happens in one single cycle. But what we try to do if we're doing it through, with treatment, is to do what's known as super ovulation. And that is, rather than giving you just one egg to release, maybe we can get you to release 2 eggs, possibly even 3. Kind of depends on your age. At 37, you're kind of right on the border there. I'd feel very comfortable with 2 follicles in your ovary, but potentially even 3, because if you do that and you do timed intercourse, assuming that you have normal sperm counts, you're going to get, more targets there potentially for sperm to be able to fertilize. And that is a good thing. Now, that low AMH or diminished ovarian reserve that you talk about does not mean that you can't get pregnant on your own. What it means is that, okay, well, we know that when we give you medication, we're going to be more limited in the kind of response we can expect from that medication. That's really the only thing that the lower ovarian reserve or the lower AMH tells us about. So I think super ovulation with timed intercourse is a fine thing to do. The question there I would have is, I just want to know for sure that the sperm count is adequate. Because when you're doing something like an IUI, well, if the sperm count is a little on the lower side, IUI or intrauterine insemination does make a big difference, because you're selecting out the best and the strongest sperm, and you're placing them inside at just the right time so that you can maximize the odds of a sperm being able to meet the egg. Doing timed intercourse is a fine way to get sperm there, as long as there's plenty enough sperm to get there. What's enough sperm? Well, we say in nature that we need about 20 million motile sperm or swimming sperm in order to reliably be able to get one single sperm on target. So we're pretty inefficient with the way we reproduce. 20 million sperm in order to get one sperm there. Wow, that's tough. If the guy had 20 million sperm and came in and the couple said, we really just want to do timed intercourse, I'd say, okay, you certainly can. That ought to be enough, but I think we would increase your odds by doing something like an IUI, because even though it's normal, it's low normal. Now, if his sperm count was, 200 million, then I'd say, sure, timed intercourse all day long. But you know what? Let's see if we can't get you to release more than one egg so that we've got more targets for those sperm to reach. Hi, Dr. J. Reagan Harwell. Hi, Reagan. Good to see you here tonight. Guess what time it is, folks? It is 5:30, and it is time for the 5:30 fuzzies with Fink. And what the heck are the fuzzies with Fink? Well, we talked in the beginning here about, how challenging the holidays are for some people. Maybe it's because of fertility issues. I think, there's a lot of folks on here who are going through fertility issues, and that's probably a good reason to be watching Fertility with Fink. But there's other things in our world as well. There are things related to family, things related to work, things related to relationships. The world is not an easy place. Bad things happen to good people. People feel lonely. People feel afraid, and people sometimes feel like they are, at the end of a road rather than seeing that they're actually at a crossroads. This is our opportunity for all of us to stand together as a community, to send out our positive vibes and our well wishes to everyone out there who needs our help. And there's a lot of folks out there who need our help. I have said before that I think this is a very special group of people who tend to watch this program, who would do really just about anything to help somebody else who's on the show who is having a hard time with things. And so I want each and every one of you to know right now that we're all here, that you're not alone, that we can get through this situation. We can solve this problem, whatever it is. There's nothing that's too big that if we put our minds to it, we can't fix. So at 5:30, I want to break the internet by everyone sending out the most positive vibes they can to everybody else who is on this broadcast and everybody else who just needs it. And if you've got a friend or family member or someone in your world who you know about, say their name out loud right now. I've been in the habit of kind of going through the list here and saying the list of everybody's names, but the list is kind of long. And really what I want is I just want good vibes going out to everybody, from each and every one of us to each and every one of us. You're not alone in this, and there will be happy times ahead, no matter what the problem is. And that, my friends, is the 5:30 Fuzzies with Fink. Please ask your friends to join us next time, even if it's only for 2 minutes, from 29 after until 31 after, so that we can really get as much positive spirit and energy as we can going in, so that everybody can hear those thoughts. Hi, Kimmy girl, and don't buck me off. I like the name. Roz Johnson. Hello, Zenaida in Miami. Thank you for being here this evening. Laurel Trev is here. Timmy is here. Hello, Timmy. Timmy, I appreciate you being here. I really, truly do. Jen Hardwick over here on the Facebook side says, you are loved, you are seen, and you are heard. And my friend, that is exactly, I couldn't have said it better myself. That is the sentiment that I am trying to share here, that each and every one is loved, seen, and heard. And you know what? Just knowing that can really make a difference in your life. So thanks for saying so there. Dr. J, thoughts for of stem cell for ovaries in women over 40 with diminished ovarian reserve. So ovarian stem cells is still really quite experimental. And in fact, I don't actually know anybody who is doing stem cell therapy. So stem cells are cells that exist within our body that can become, they're called a multi-potential. They can become any other type of cell. That's what a stem cell is. That you could take one of these cells and it could become a piece of bone. It could become a piece of tissue. It could become a blood vessel. It could become a nerve. And what you put it where it needs to be. And the thinking is that it will become part of that tissue. So they use this type of therapy, stem cell therapy, in things like damaged joints. So if you have a meniscus tear, theoretically, if you're not a candidate for surgery on that, you can take stem cells that can be derived from fat, so they can come out of the, you do a little lipo on the belly or in the love handle, and isolate the stem cells, and then inject those stem cells back into the place that you need them. In this case, in the ovaries, and or we're talking about in the meniscus, in the knee, and it helps that meniscus to heal. So the same thought is that that can happen in the ovaries. But again, I don't know of anybody who's doing stem cell therapy in the ovaries. What we do is called intraovarian PRP. And PRP is platelet-rich plasma. We take a sample of your blood and separate out not the stem cells per se, but rather your body's healing tissue, your growth factors, the things that help your body to heal. And then we can inject that PRP into the ovaries, typically under a little anesthesia, get a little sedation, and we place your own healing tissue into your ovaries with the hopes that it's going to help to regenerate some new blood flow, that it may, and then it may be helpful in terms of egg quality. So that is something that is also experimental, and I do think there's something to it, but the issue is we just don't know exactly who it's for and who it benefits. So, some people call it ovarian rejuvenation. But I don't think that's accurate, because, I could take someone who is, let's say, 55 years old and is in menopause, right? The average age for menopause in the United States is 51.4. But let's say that you're 55 and you're menopausal, and I put PRP, or for that matter, even stem cells in your ovaries. It is not going to make you premenopausal again. So we can't make eggs appear where there are no more eggs. Where I think it can benefit folks is in the situation where there's an issue with egg quality, that maybe you have a normal ovarian reserve, or for that matter, maybe you have a lower ovarian reserve, but either way, you're worried about the quality of the eggs that you may make. So putting that tissue in may help you to make healthier eggs. Problem is, right now it's still experimental. We just don't know the answers to these questions. And there's a lot of study going on. Hopefully, within the next couple of years, we'll have really some more defined answers on who is the best candidate for something like the intraovarian PRP. Or potentially even stem cells. Laurel says, if my first FET failed, would you change the protocol for the second transfer or try again with the same protocol? Well, so, when we talk about protocols, we're really talking about, are you doing a medicated cycle or are you doing a natural cycle? The medicated cycle is where we're giving you all the estrogen and all the progesterone you need, and that we are suppressing your body's ability to make that estrogen and progesterone, because we want to control every variable. We want to leave everything, anything to chance, we want to leave out of the equation. Oh my goodness, I'm sorry. I just yawned. Oh boy, on live TV here. Sorry about that. That kind of day, that's a medicated cycle. In a natural cycle, we're letting you ovulate, because just like you do in a normal menstrual cycle, in the first part of the cycle, you build up an egg, and that egg makes your estrogen, and that estrogen thickens up your uterine lining. And then we get you to release that egg. And when you release that egg, that little estrogen making area becomes a little progesterone factory. and it creates that's where your progesterone comes from. So you don't have to use the extra estrogen, and you don't have to use the progesterone in oil, which is something that is really kind of a great thing. Now, these two methodologies are said to be equivalent, that the outcomes are really said to be the same. And so in most cases, I would say either one is probably fine. Now, I have some caveats to that. Let's say that you did a medicated cycle. I wouldn't necessarily say, oh, okay, well, it didn't work, so now we're going to switch it. We're going to switch it to a natural cycle because the medicated didn't work. I don't know that that is necessarily grounded in any evidence, but there may be some situations where we say, oh gosh, maybe you did a natural cycle, or maybe you did sort of a low intervention medicated cycle, just some estrogen and progesterone, whereas really you might do better if we fully suppress you, if we give you some Lupron, daily dose Lupron, along with your estrogen and progesterone. So we can really make sure that we are indeed controlling every variable. So, there are some nuances there, but I wouldn't necessarily automatically say that because one type of cycle didn't work, that we should switch it up. In most cases, Laurel, and I think this is really important for everybody to hear, that we always go looking to say, gosh, if we only did something different, if we only handled this differently, if we only we should make sure to test mom for A, B, C, D, E, F, and G, because what happens if something like that is there? In most cases, it's not a uterine problem. In most cases, it is not a protocol problem. In most cases, it's an embryo problem. So, I would say, in this practice, for instance, we right now predominantly do medicated cycles. And there are some reasons for that, and different doctors have different opinions on why that may be and on what may be the best. But, ultimately, they're said to be equivalent. And even with that medicated cycle, if one doesn't work, we don't say, oh, obviously there must be some problem with the medicines we use. It's the same estrogen and progesterone. So, we kind of go at it again, but with a different embryo. And most of the time, it is indeed an embryo issue. Hi, Lenac and D. Casperd, I think that says, is it possible that a uterine PRP wash or HCG wash can cause a uterine infection? You ask a good question there. We talked just a minute ago about PRP. PRP, and we talked about using it in the in intra-ovarian, but using it intrauterine is a pretty well established intervention in some cases, particularly in folks who are have a problem making enough uterine lining, or in some scenarios in people who have had a recurrent pregnancy losses. We can place PRP inside the uterine cavity. What happens? You do it just like you do with the HCG wash. You put a little of the liquid in a syringe on a little thin straw that goes into the cervix, and you just slowly inject it to the inside and let that liquid bathe the lining. I think the PRP is really the most healing type salve you can create for the uterus. But is it possible to create an infection? The answer is yes. Why is that? Well, because we're taking something and we're putting it inside the uterus. The uterine environment is supposed to be, by and large, pretty much a sterile environment. But you've got a catheter, a little straw that's going through the vagina, which is absolutely not a sterile environment. There's a lot of bacteria that live in the vagina, and you're placing it through the cervix and you're placing it up into the uterine cavity. What happens if there's a little bit of bacteria right there in the cervix from the vagina and you drag that up into the uterine cavity? Yeah, it can cause an infection. So that's why I say we don't recommend doing these things kind of willy-nilly. There is always a risk to everything that we do. There is a risk to embryo to egg retrievals. There is a risk to embryo transfer. There's a risk to doing IUIs, and really even there are risks associated with even just doing timed intercourse with ovulation induction. So yeah, you can get an infection. Now, fortunately, it's not all that common, Angela. So not something that we would expect to have happen. And we really don't see it clinically all that much, but could it? Oh yeah, absolutely, it could. Hey, Midgie, nice to see you this evening. And Rashmi, let's see. My dear friend Angelina up there in the great white, I guess that's considered Midwest, and it is all white and snowy now, right? You guys, when you live on the Gulf Coast, you kind of start to when I lived in Colorado, I really forgot all about what it was like living in the tropics because I lived in Miami and the Florida Keys for 20 plus years, and practiced there. And we felt like we had a big target on us from the hurricanes. Every hurricane season, you would watch, each and every storm inch its way closer and closer to you over the course of days. I mean, it became really quite exhausting. Well, when you move away from that and you live in Colorado, you start thinking a little bit more about wildfires in the summertime, for sure. But then, you get these snowstorms and you forget about it. And now living back in Florida again, I've kind of forgotten what it's like to get all those big blizzards. And you guys up there in Minnesota probably got some pretty cold weather there. So I don't envy you for that, but I'm very happy to see you this evening. I will say to everyone, Angela is a wonderful nurse practitioner, a cardiac nurse practitioner. So she fixes people's broken hearts and does just a wonderful job. And she has a beautiful child and a beautiful husband as well. So Angela, so nice to see you this evening. Pleasant Hill says, "Oh, you're awesome, Dr. Fink. Thank you for saying that. I sure do appreciate that." Minji asks, "Do you recommend PRP prior to an FET?" And I would say, no, not necessarily. PRP, if you've had a number of pregnancy losses, that I think is a reasonable place to say, what, PRP might be a good idea. Or by the same token, if you're having issues growing your uterine lining, then that's the time for PRP. But I would not recommend PRP necessarily routinely for everyone because I just don't. There's no evidence to show that it's helpful in the general population who may just otherwise be able to, implant an embryo. Let's see. Hi to Ocean. Nice to see you this evening. Laurel says, "Thank you." Jake Esquire. Hello. Nice to see you. Do you recommend a luteal phase cycle? All right. So what are we talking about with a luteal phase cycle? So, the menstrual cycle has basically two halves. There is the what we call the follicular phase, and that's the first half of the cycle, and that's the time at which you are growing an egg. That egg is building up, and you're making estrogen. Right about in the middle, you have ovulation. And once you ovulate, you start making progesterone. And the second half of that cycle is called the secretory phase or the luteal phase. And it's called that because the space where the ovary releases its egg is called a corpus luteum. It creates a little cyst in the ovary. And again, this thing about cysts are a natural part of every ovary in a cycling woman for sure. So the little cyst that gets left behind is what makes progesterone, and that's what causes that luteal phase. There is some evidence that using stimulation in the luteal phase can be beneficial, and that is especially true in folks who have had either a poor outcome in a standard type stimulation cycle. Folks with diminished ovarian reserve may benefit from doing a luteal phase stim. So this month, for instance, I happen to be doing probably 5 or 6 luteal phase stims, because that's the folks in whom it seems to benefit, and just happen to have a whole bunch of them. Let's say that you had some kind of illness, maybe, heaven forbid, something like a cancer, and that we had to get eggs from you because you had a hard stop when you were either going to have some surgery or had to start some chemotherapy or something. We would start a stimulation at any time during your cycle. We can start it in the beginning. We could start it when you're ovulating. We could start at luteal. It is said that there are at least 2 phases of what we call follicular recruitment. The first one is the one that we know about, and that is the beginning of the cycle. That's why our standard stimulation is that we give you that medicine at the beginning of the cycle. It's the same thing that your body is doing naturally. But in the first part of the cycle, there are going to be some follicles or some eggs that have not been recruited to do a job, to fight with each other and figure out which one is the one that's going to get ovulated. Or if you've done a stim in the first part of the cycle, they may just not much has happened with them. And that's the benefit there of the luteal phase stim, that you get a second wave of follicular recruitment, and that's in the second half of the cycle. And so, yeah, definitely there can be a benefit from that. But again, that too is not for the general population. It is usually reserved for those with a diminished ovarian reserve, or folks who have had issues with egg quality or something like that before. Getting a receptiva test, a biopsy, is it done in the same way as getting a biopsy for endometritis? And the answer is yes. It's an endometrial biopsy, and that is this little straw that goes through the cervix. And what it is think of a straw that has a little plunger on the end. And the straw goes inside. We pull the plunger back, and that creates this little tiny cylinder of suction that will pull some of your tissue into that straw. So as we rotate it and take it out, it goes, and it does, in fact, make that noise. And then you place that tissue into a little jar. So receptiva is a test for endometriosis. It looks for the marker that's known as BCL6, and it is done through the standard type of endometrial biopsy. Yes, indeed, the same way as you would test for endometritis. Now, the receptiva test can also test for endometritis. So just as an FYI, you can get it all done sort of at once if you want to. But yep, same type of little endometrial biopsy. It's not 10 tons of fun, I gotta say. It's crampy to get that endometrial biopsy. Anybody who's had one knows it's not something that you want to do every day. But fortunately, it's very fast. Fortunately, it takes just a few seconds and then it's over, and it shouldn't leave you cramping all day long like you had a big surgery or anything like that. But usually I tell people by the time you walk out the door and get to your car, most of that cramping, really ought to be gone. Haley, hi Haley. Haley asks, can miscarriage after IVF trigger anxiety or panic attacks because of hormone decline? Well, that's a complicated question, Haley. And what I would tell you is that going through the process of IVF is very, very stressful. And then having something like a miscarriage happen is almost, insult to injury. It's a very cruel thing to have happen. And I have experienced many a folk who end up really being triggered by thoughts of things like miscarriage and almost even some post-traumatic stress as a result of having to go through IVF and having a miscarriage. Now, that alone is real. 100% that's a real thing. Then you add hormone fluctuations on top of it. And I would say, well, you're talking about, something that may be truly significant. I can't say that it's because of hormone decline per se, because people get panic attacks, people have anxiety, and they have it, irrespective of what their hormones are necessarily doing. But when you talk about fluctuating levels of hormones and high levels of hormones that may be resolving, let's say after a pregnancy, after a miscarriage, or certainly, after going through the whole process of IVF, that change in hormones may be enough to really make you not feel like yourself. And then adding the trauma of the pregnancy loss can really add to that. So I think the answer is yes and no. The struggle is real, Haley, for sure. The hormonal changes are real. Are they, black and white, a causal connection that it's hormonal changes that are triggering it? No, I think it's probably the stress and the trauma of having to go through it that is made worse by those changes in hormones, if that makes sense. My friend Blackskin says, what supplements do you recommend for diminished ovarian reserve and also to help with my husband's swimmers to prepare us for timed intercourse? So 2 things I want to share here. First is, as far as the protocol for diminished ovarian reserve, it's kind of lengthy. I'm happy to send that to you if you will message me on that. And again, happy to send that to you. I wrote a little book on it. It's an ebook. It's called The Vitamin Victory, and $7, and you can get that ebook at my look at the link on my Instagram, which is Randy Fink MD, and that will take you to the link for the ebook. It is, I think, well worth it because I happen to think it's a pretty good book, but you also get a coupon that'll get you about $25 off getting those supplements if you would like to purchase them. But I'm happy to send you that list also if you don't want to buy the book. As far as helping swimmers, helping sperm, the 2 most important things. Oh, thank you. Marlena says, great book, easy read. I appreciate that very much. And a special hello going out to Red Bear. Nice to see you this evening. I think for sperm, probably the 2 most important things are, 1, CoQ10, and that's 200 milligrams a day. Is really all you need. You just need a little bit of CoQ10. They say 200 to 400 milligrams. You can take 1 or 2. You can take 1 in the morning and 1 at night. I think if you want to just cover all bases, that's a great thing to do. Or you can take 2 together. 400 is a good dose. 200 is probably adequate. But it also, for a woman, it really depends on what type of CoQ10 you're getting, whether it's the ubiquinone form or the ubiquinol form. But for sperm, CoQ10, let's call it 400. And the other thing is omega-3 or fish oil. Get your fish oil. It makes a difference. So fish oil can also be called DHA or EPA. DHA not to be confused with DHEA. That's something different. But DHA and EPA is omega-3. It's fish oil. If you're going to get the fish oil, get the one that says it's odorless or burpless, because you'll burp it up. It literally comes from a sardine, and you won't want to be in the same zip code as that bottle again. I actually I just told somebody today, I think it was, I remember I got a bottle. I saw them at Costco, and it was like, $1.99 for 1,000 omega-3s. And I took one of them, and then I set the bottle on fire in the backyard because it was so horrific. It was so heinous. I never wanted to experience anything like that again. So odorless or burpless is important in the omega-3 department. Red Bear asks, later if you get a chance, I've been on letrozole. I've been bleeding all 5 days. Is this okay? Will it interfere with my IUI? Hmm, that's interesting. So typically letrozole, well, actually, you may have been on some birth control before that. And so you were taking the birth control, you're getting a withdrawal bleed probably from the birth control. And no, so it really shouldn't affect that. If you had a natural cycle and you're still bleeding by the time you start your letrozole, I'd say, yeah, that's a little unusual, but it really ought to be tapering off about now, that bleeding part, and it should not have an effect. One of the things that we will look at when it gets closer to IUI time is to look at your uterine lining to make sure it has built up enough that it's nice and thick and warm and juicy to make a place for your baby to implant. Let's see here. What else we got there? Angela asks, I had one cell of CD138 cell count in 10 high power fields. The nurse had me to do antibiotics, but I thought it was anything under 5 is fine. So yes, so what they're looking for there are cells that are called plasma cells, and the plasma cell is a marker for endometritis. When they just look for plasma cells, they talk about 5 or more cells per high power field is considered a positive diagnosis. They can do a stain for those plasma cells, and that's what the CD138 is, which means they can just see them a little bit better under the microscope. It makes it a little easier to see. If you had one plasma cell in 10 high power fields, I would not say that's a positive test. And so to treat it with antibiotics is probably, realistically, it's probably a little bit of overkill. Did it hurt anything? Probably not. But technically speaking, you are correct. 5 per high powered field is considered diagnostic for plasma cells in endometritis. Folks, we're going to be all out of time tonight, but I hope you will join me next Tuesday at the same time for Fertility with Fink. Every single day is a challenge in our lives for one reason or the other. I say repeatedly, please do everything you can to take every step forward with love, every step forward with kindness, because there's not enough kindness in our world. And if we could only share that with one another, and that's what we do at the 530 Fuzzies with Fink, stand together as one and share that kindness. But I also want you to take every step forward with hope, knowing that tomorrow is a new day and it's full of all new adventures. You know, the fertility business is not the book of your life. It's just a chapter. And we're going to rewrite that damn thing. What do you think? Thanks so much for being here tonight. From Pensacola, Florida, I'm Dr. Randy Fink. Good night.